Hi everyone, Olivia Hensey here. I'm going to go ahead and mute all the lines right before we get started. I'm going to do that right now. You should hear a command that all your lines have been muted. Alazy, Sarah, and our presenters, if you could just press #6 to unmute yourselves after.
Good morning everyone. My name is Alazy Victor from the New England QIN-QIO, and I will be your moderator for today's webinar. Section 1, Introduction to Antimicrobial Stewardship in Long-Term Care. Thank you for joining us for today's webinar. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with detail on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end of the presentation. I will provide you with instructions on how you can ask a question over the phone or pose a question in the chat box. Please make sure to send questions to all attendees. At this time, I'd like to introduce Carrie Barton with the Massachusetts Department of Public Health. Carrie, will you please? Go ahead.
Hi. Yes, thank you. It's my pleasure to introduce Dr. Shira Doron and Dr. Beaulac today. Shira Doron is a physician in the Division of Infectious Diseases at Tufts Medical Center. She has been the physician head of the Antimicrobial Stewardship program there since 2005 and is also the Associate Hospital Epidemiologist. On a national level, Dr. Doron serves on the Society for Healthcare Epidemiology of America Antimicrobial Stewardship Subcommittee and the Infectious Diseases Society of America Antibiotic Stewardship and IV Leadership Working Group. Here in Massachusetts, Dr. Doron has been involved in several statewide initiatives to improve the care of patients with suspected or confirmed infection. Dr. Doron has numerous publications related to antimicrobial resistance and stewardship. Dr. Kirthana Beaulac is a physician who trained at Massachusetts College of Pharmacy, completing postdoctoral training in infectious diseases at Hartford Hospital. She is the pharmacist head of the Antimicrobial Stewardship Program at Tufts Medical Center, as well as the infectious disease pharmacist for the institution. Dr. Beaulac is involved in the Massachusetts Society of Health System Pharmacists, the Council of Boston Teaching Hospitals for Pharmacist Education, and the Society of Infectious Disease Pharmacists. Her research focused in methods of optimizing antimicrobial use. Thank you both for speaking today, and really excited to kick off this 6-part webinar series on antimicrobial stewardship. Thank you for the introduction. Again, my name is Dr. Beaulac, and we will be talking today about antimicrobial stewardship in long-term care. For some reason, the slides are, oh, there we go.
Perfect. Thank you, Shira.
Thanks. As I mentioned today, we're going to talk a little bit about antimicrobial stewardship in long-term care to really give an introduction to what it is and to kind of relay to you the importance of this process in the overall delivery of health care. For those of you that are familiar with antimicrobial stewardship, do you feel like, can the moderators please open the polling question? We were hoping to get a sense before we even start to get a sense of whether you feel like your facility has an antimicrobial stewardship program in place, if perhaps you think that you have a feasible plan to implement a program, or really doesn't have a program in place at all for antimicrobial stewardship at this point. So please enter your responses.
Emily or Jennifer, could you please open the polling question? Emily or Jennifer, if you're on the line. Oh, there we go. Perfect. So again, there's 30 seconds to answer this polling question. Thank you so much. Now, unfortunately, sometimes there's another 30 seconds added on. If you don't press submit, we should have let everyone know that. When you do answer a polling question, if you could please press submit, that would be great. The answers should be up momentarily. If you'd like to continue, they should be up very soon. Oh, there you go.
All right, so it's kind of spread across the board that so we've got 43 respondents that have a feasible plan to implement the program, so we're really on their way to having an antimicrobial stewardship program with 16 respondents actually having a program in place, which is very impressive, and 27 respondents that don't really have much in place, and hopefully we can use this webinar series to help change that. Okay, so many of you are here for a very well-known reason, which is that there is a problem. Antimicrobial resistance is increasing, antibiotic use is increasing, and it's kind of this vicious cycle that there's a snowballing effect with this arms race between the bacteria and the bugs that are wreaking havoc across our healthcare continuum. Specifically in nursing homes and long-term care, since nursing homes and long-term care are such a major subset of our overall healthcare utilization, and the fact that 4.1 million Americans live in nursing homes each year, they consume astronomical amounts of antibiotics. 70% of all nursing home residents will get at least some antibiotics in any given year, and 40% of all systemic antibiotics that are used in the United States are used in long-term care facilities. So this is a huge, huge, huge area where antibiotics are being consumed at a very, very, very rapid rate. Now, when you compound the fact that up to 75% of antibiotics are used incorrectly, whether it be inappropriately or perhaps are unnecessary, that represents not only millions, if not billions of dollars, as well as all of the negative consequences that come along with using antibiotics when they're not necessary. So this is really focused on this kind of heavy utilization population, which is long-term care. When we think about the fact that not only is this a big population, but it's a growing population. As the United States population is aging, healthcare utilization in long-term care is going to grow along with it. And this problem that is in place is just going to get even worse. And as I mentioned, there's this arms race that as we continue to use antibiotics, rates of antibiotic resistance are increasing as well, because we know that the use of antibiotics can cause resistance. So as we see third-generation cephalosporin resistance is increasing at the highest rates in nursing homes, as well as carbapenems, which we think of as our last-line antibiotics, rates of resistance to carbapenems is also increasing dramatically in recent years. So we're struggling to treat these multi-drug resistant infections because of all of the increasing resistance that we're seeing. Okay, so one may think that the easy solution is just to create new antibiotics, because if the bugs are changing, maybe our drugs should change too. However, that's just not happening. The number of new antibiotics that are coming through the pipeline it's just not coming that quickly, and even of these 6 new antibiotics that came out in the past 5 years of this decade, only one of those was a new chemical entity, whereas the other 5 were just modifications of currently existing drugs. So although it's great to have more antibiotics when they're just me-too drugs, it's not actually solving the problem that we're running out of options with these multi-drug resistant bacteria. So as we try to put out this fire that's burning out of control, the pipeline is really drying out for us. And we're slowly reverting back to what's known as a post-antibiotic era. So Dr. Margaret Chan put it well in saying that this post-antibiotic era means that we can have an end of modern medicine as we know it, and things as common as strep throat or a scratched knee could once again be lethal because the bacteria will, over time, grow resistance to all of the antibiotics that we currently have available to us. It's not all doom and gloom, but it is a significant problem. And in last year, the CDC compiled the risk of all of the different bacteria in the antibiotic resistance threat document that they released based on data from 2013. And they did a total national summary of all of the different threats and really quantified the burden that multi-drug resistant bacteria and C. diff, which is another major consequence of antibiotic use, quantified the burden on our healthcare society. And what you find is that there's 23,000 deaths each year from drug resistance and 14,000 deaths from C. diff each year. So we put that together, the deaths from inappropriate antibiotic use is 37,000 deaths per year. That may not sound like that much, but when you compare that to deaths from motor vehicle accidents being only 32,000, deaths from homicide being 15,000, and we're seeing more people dying from inappropriate antibiotic use than guns. So it makes no sense that we have all of this regulation surrounding safe gun use and safe road rules, seatbelts and speeding limits, but we don't have the same type of control over this problem that's causing even more deaths each year. When we bring it back to our long-term care population, not only is this a major problem for the entire population, but 83% of these deaths are occurring in our older patients or patients over the age of 65. So it's really, really focused in that long-term care elderly population. So not only is this a national problem, but it's a national problem that's really, really kind of magnified in the long-term care setting. The CDC was able to stratify how significant each of the microbial threats are and really classified the urgent threats as Clostridium difficile or C. diff associated diarrhea, carbapenem-resistant Enterobacteriaceae, and drug-resistant Neisseria gonorrhea. There are other serious threats that they've listed, like multi-drug-resistant Acinetobacter, fluconazole-resistant Candida, vancomycin-resistant Enterococcus or VRE, which are prevalent but not as urgent. And there are some up-and-coming resistance threats that they consider concerning but not as concerning, being vancomycin-resistant Staph aureus, which is a very serious problem when it happens, but very uncommon at this point, as well as erythromycin group A strep and clindamycin group B strep. So the CDC has really been able to facilitate us in focusing our efforts as these drug-resistant bacteria are causing a significant morbidity and mortality burden in our long-term care population. Not only do we worry about the risks that these bacteria can play on our patients, but we also think about what are the risks drugs that we use to treat these bugs. So it's also noteworthy that antibiotics are not innocuous. Antibiotics are responsible for 1 out of every 5 emergency department visits for adverse effects, and 140,000 visits each year are strictly attributable to allergic reactions to antibiotics. But then there's many other consequences that we see from antibiotics, including C. diff-associated diarrhea, drug interactions that were not considered at the time of prescribing, and side effects, which can range from very serious side effects or even kind of simple common side effects like nausea or diarrhea can present very profoundly in the elderly population that can actually cause severe dehydration requiring hospitalization and intervention.
It's only the dial-up number to get on it.
This is Olivia. I'm sorry. I don't mean to interrupt. I'm going to go ahead and mute all the phone lines again, just because I hear a little bit of background noise. So I'm going to go ahead and do that. And if you could just press #6 to unmute yourself, that way we won't be interrupted. Thank you.
Thank you.
Okay.
So this
go ahead.
We think about microbial stewardship having a role in that it's a program that will hopefully decrease the rates of antibiotic resistance, decrease the rates of C. diff infections, and also ideally decrease costs for your institution because we're likely getting rid of the unnecessary use of antibiotics and the consequences of antibiotics. Along with that, we're hoping to improve patient outcomes by improving the quality of the care that we're able to provide to them. There's a lot of hurdles that can come along with this practice, but it's really just all about promoting best practices. So making sure that all antibiotic orders have the right dose, duration, and an appropriate indication. And encouraging things like the use of blood culturing or appropriate culturing of infected sites. And considering an antibiotic timeout. So it can be challenging to diagnose an infection. So even if antibiotics are started, the patient is not always committed to a full course. If after 40 to 72 hours it seems like it's not really an infection or perhaps a narrower or safer option could be appropriate, it's really appropriate to take that time out to reassess the potential options. And it has been proven time and time again in various settings that having a program like this causes significant financial savings that justifies the cost of a program. It's been proven in acute care, long-term care, long-term acute care, in community hospitals, and in every setting possible. This is a cost-saving initiative. This antimicrobial stewardship program, we have to kind of toe the line of making sure that we are providing appropriate initial antibiotics that is going to be improving health care. We don't want to withhold antibiotics to patients who are actually sick, but also balancing that out with not providing unnecessary antibiotics and exposing our patients to unnecessary risks and adverse effects. And also, as I mentioned, the cost associated with all of these unnecessary or inappropriate interventions. A lot of times what it is. So we encourage things like optimal drug selection, choosing the narrowest possible antibiotic, choosing the appropriate dose, incorporating some of the patient-specific factors like their kidney function or perhaps the patient's weight, and then choosing the right duration, which is always a moving target, but using the shortest possible appropriate duration of an antibiotic that's going to result in a cure that minimizes unintended consequences like the emergence of resistance, adverse drug events, and cost. And overall, with all of these antibiotic changes, we hope to inevitably improve
Excuse me, I'm sorry. I'm sorry, it's Olivia. I don't mean to interrupt. It sounds like there's still some background noise coming in through the phone that we're unable to manually mute. If all participants could please manually mute their lines, I think we would all really appreciate it. Thank you. I'm sorry to interrupt.
Sure. And just to remind everyone, to mute is #6.
Nope, that's to unmute themselves.
Sorry.
We just would like everybody to manually mute their own phone lines. We do try to mute everybody, but sometimes people do still come through. So if you could just manually mute your own phone line, we would appreciate it. Thank you.
All right.
My medical bag.
All right, I'm going to go ahead and mute all the phone lines again. I apologize for this, but it sounds like people are coming through. So hold on one moment, please. Okay, and you press pound 6 to unmute yourself as speaker. Everyone else, please manually mute their lines. Thank you.
Hey, so to kind of get back to the need for really improving the way we use antibiotics, because antibiotic use causes resistance. We've known that since the time of Louis Pasteur. But what we find is that antibiotic use is an independent predictor of the acquisition of drug-resistant bacteria later on. We've always thought about this kind of more of a global perspective, that overall antibiotic use can overall predict later resistance. But what we're finding more and more these days is even on a patient-specific level, that the use of broad-spectrum antibiotics can result in multi-drug resistant bacteria in that same patient later on. So it's really important on a patient-specific basis about what are the downstream consequences of every single antibiotic course that we prescribe to our patients. And it really becomes a slippery slope of once a patient gets antibiotics, they can then get colonized with a multi-drug resistant organism. And that may not cause infection right off the bat, but if something happens and they do develop an infection, it's much more likely to become a multi-drug resistant infection. And then that patient would need to be admitted to the hospital for treatment and inevitably discharged back to their long-term care facility. And then they're free to transmit that multi-drug resistant organism to their friends either in the hospital or in a long-term care facility. And it becomes this cycle of acquisition and transmission of multi-drug resistant organisms that really require significant landscape-wide intervention to stop the cycle and really kind of clean the space. So next I'm going to turn it over to my partner Shira, Doron, who's going to talk about some of the regulatory implications to help break this drug-resistant cycle.
Thanks. So painted somewhat of a bleak picture, and I hope you're not all terribly depressed right now, but I hope that you've been listening to this with the with an understanding of the level of importance of this global issue and this global crisis. But there is some hope, and in 2015, the White House, under pressure from groups like the Infectious Disease Society of America, released its National Action Plan for Combating Antibiotic-Resistant Bacteria. And that was really the first time that the federal government proposed an action plan. There was a lot of talk about the crisis, but an actual action plan took a long time to be developed, and we were excited to see this. And most exciting really was Table 2, the goals and objectives, and Goal 1 being to slow the emergence of resistant bacteria and prevent the spread of resistant infections. And objective within Goal 1, to implement public health programs and reporting policies that advance antibiotic resistance prevention and foster antibiotic stewardship in healthcare settings and the community. And that is why we are here, and that is why this program that you're participating in today exists. So I'm really excited about the action plan. And essentially there are 3 key opportunities for improvement. 20 to 50% of antibiotic prescriptions in acute care are considered inappropriate or unnecessary. 50% of outpatient antibiotic prescriptions are considered inappropriate or unnecessary. And we talked about up to 75% of antibiotic prescriptions in long-term care being inappropriate or unnecessary. And so the National Action Plan really addresses these 3 settings. Now, even the lay press has begun to gain an understanding of the issue in nursing homes. That number, 75%, incorrect prescriptions, is obviously very, very concerning. And there's an entire section of the CDC website that's dedicated to stewardship and long-term care. This initiative is led by Namali Stone, and I encourage you all, if you have not been to this website, to take a look at it. It is full of really useful resources for implementing antibiotic stewardship
in nursing homes. And I'll just show you one key example of what you can find on this website, and that's the checklist for core elements of antibiotic stewardship in nursing homes. And there are many detailed actions within this checklist that are all things that should be happening that you should be planning to do in your facility, and they are in the categories of leadership support, accountability, drug expertise, actions to use, tracking, reporting, and education. So I will ask for Emily to open the polling question again. I'll read the polling question out loud, and then as you're answering, I'm going to go back to the checklist so you can look at it as you're answering. So you can look at the specific elements under each of these categories. So the question is, my institution currently has the following antimicrobial stewardship elements in place, and we'd like to hear who is doing things in the area of leadership support, accountability, drug expertise, actions to improve use, tracking, which includes monitoring antibiotic prescribing, use, and resistance, reporting information to staff on improving antibiotic use and resistance, and education. And you can answer all of the things. I guess I can't go backwards, sorry, to look at the details, but you can answer all of as many times as you want in any of the categories. Oh, here we go. If you can see this, I'm showing you some of the.
Yeah, the polling has ended. The results should be available on the screen momentarily.
Okay, great. Okay, so what we are looking at here is a pretty fairly even distribution. So a lot of you out of about 50 people who responded, it looks like a lot of you are doing a lot of these things, and I'm happy to see that actually the largest percentage respondents are tracking, which is one of the hardest things. And something that we'll be talking about in much more detail in future webinars. Leadership support obviously is incredibly important, so I'm also glad to see that we have 36 respondents saying that they have that, which is fantastic. And it looks like the biggest struggle people are having is in the areas of drug expertise and accountability. And we can definitely talk more about those topics in future webinars, and we'll keep that in mind as we prepare future webinars for you. Just trying to move forward here. Let's see. Okay. So CMS, the Centers for Medicare and Medicaid Services, proposed their new regulations in 2015 with respect to long-term infection prevention and antimicrobial stewardship requirements. And this is all part of the National Action Plan. CMS got in the game and decided to require facilities to perform facility-specific assessments of the resident population and their facility, and requires long-term care facilities now to have an antibiotic stewardship program that includes antibiotic use protocols and a system for monitoring antibiotic use. So we're going to take an interactive break. This is not a poll. What we're going to ask you here is enter your thoughts in the chat box. And the question that we're posing to you is, what are some of the challenges that you're facing associated with implementing stewardship in long-term care? If you could enter that into the chat box and make it visible to all participants, then we can share some of those with the audience. And again, that is going to help us to develop future webinars that you'll be able to participate in. So we're already seeing some recurring themes. Time. Time is obviously a huge issue. Who has time in their busy work week to put a new huge initiative into place? And that's obviously a very tough one, and that really relates very closely to leadership support and at time to a project like this. It also relates to leadership prioritization and the facility being able to put resources into such a project. And sometimes it does require bringing in a consultant or bringing somebody in to put those hours in if you're maxed out. Family expectations and patient expectations. That is something that I've been hearing about and dealing with for many years in the long-term care setting. There is obviously an expectation that patients are given antibiotics often at the first sign of something like altered mental status. Altered mental status, as you know, is not an infection. And altered mental status, as you know, is part of the changes in mental status from day to day are part of the normal progression of dementia. And when families believe that antibiotics are what makes their loved one's mental status improve, it can be very hard to convince them otherwise. And we've done some projects sponsored by the state in the past where we actually used role-playing a lot to teach providers how to have those conversations with family members. Even more difficult can be providers and staff really understanding these concepts and coming to the realization that antibiotics are not always the answer. And the key there is to have antibiotic use protocols in place so that you can always refer back to that standardized practice. If patients don't meet certain criteria, they don't get antibiotics. That's a lot easier to implement than having to have a discussion, a contentious discussion every single time antibiotics are being and so I see they're needing more specific guidelines. Absolutely. Guidelines, protocols, algorithms are so key to successful antimicrobial stewardship. So these are really great comments, and we're going to take all of these into account as we prepare our future webinars. Moving forward, let's see. The Choosing Wisely campaign, this is another website that I hope that you're familiar with, and if not, that you take a look at. This is an initiative of the American Board of Internal Medicine, and there's a whole section of Choosing Wisely that comes from AMDA, which is essentially the Society for Post-Acute and Long-Term Medicine, and they have this statement, 10 things physicians and patients should question, and includes things that do and do not relate to infections and antibiotic use, so things like not inserting percutaneous feeding tubes in individuals with advanced dementia and suggestions about not using sliding-scale insulin. But relevant to our initiative here, there are a number of items. Don't obtain a urine culture unless there are clear signs and symptoms that localize to the urinary tract. We're going to spend almost an entire webinar discussing just that issue because it is so unbelievably common in the nursing home setting. And urine analyses and urine cultures are sent so often without symptoms specifically referable to the urinary tract. So that's an enormous area that you can see improvement in right away if you implement the appropriate protocols. Don't place an indwelling urinary catheter to manage urinary incontinence. Urinary incontinence is better managed in other ways, and urinary catheters are a very big source of infection. But more important is patients with urinary catheters are always going to have positive urine cultures, even in the absence of infection. Number 8, don't obtain a C. difficile toxin test to confirm cure if symptoms have resolved. So patients who had C. diff with diarrhea, who no longer have diarrhea, should not be retested. Those tests are going to come back positive, and they're going to lead to prolonged courses of antibiotics for C. diff, which actually increases that patient's risk of future C. diff. So this is the document, which I hope that you will take a look at. The most common infections treated with antibiotics in nursing homes, as I mentioned, urinary tract infection is a huge source of antibiotic use at 32%, respiratory infection at 33%. And less so. Wound infections, again, are another area where cultures are always going to be positive, even in the absence of true change, clinical change, in the absence of true infection. Open wounds are supposed to have bacteria. They're open to the outside world and do not need to be treated unless they appear to be clinically infected. So here are some common long-term care scenarios in which antibiotics are not needed. Again, we're going to get into more detail about these in future webinars. We talked about positive urine culture in the absence of symptoms, and believe it or not, cloudy is not a symptom, and smelly is not a symptom. Upper respiratory tract infections, common colds. Everyone knows that common colds do not require antibiotics, but even if there's fever, antibiotics are not indicated. Even if there's bronchitis, even if there's green sputum, even if there's green nasal discharge, those are not clinical criteria for antibiotics, and these are easy areas in which to create algorithms for antibiotic use. Abnormal chest x-rays without signs and symptoms of respiratory infection. Who knows why a chest x-ray is sometimes done, but in the absence of respiratory symptoms, abnormal chest x-rays should not be treated as pneumonia. We just talked about positive wound cultures in the absence of cellulitis, abscess and necrosis. Diarrhea in the absence of a positive C. diff toxin assay should not be treated as if it was C. diff, but also a positive C. diff test in a patient whose symptoms have resolved and therapy is completed should not be treated as C. diff. Those tests stay positive for a very long time, if not forever. And we talked about mental status fluctuations in a patient with dementia. That is not an indication for a culture at all, and there are many other interventions or assessments that are more appropriate in a patient with mental status fluctuation. In many cases, those fluctuations are obviously normal and expected. So this is our second interactive break, and again, I'll ask you to use the chat box and to make your responses visible to all participants. What are some of the steps you have considered taking to optimize antibiotic usage in long-term care? And a quote there from John F. Kennedy. So you can go ahead and tell us some of the things you're doing right now to optimize antibiotic usage, and if we see something interesting there, we'd like to share that with everybody. So we have people who are saying that they are educating staff, residents, and their families, that they're talking about stewardship weekly at their risk meetings, that they're educating providers. This is all great stuff. Identifying specific prescribers, that's terrific. That's something we actually are working on doing here at Tufts Medical Center. Using criteria for diagnosis of UTI, using things like IV fluids and closer monitoring before culturing urine in patients who don't meet criteria for UTI. Information from the laboratory. So we will talk about what kind of information you would want to obtain from your laboratory about resistance patterns that may be occurring in your facilities and creating what we call an antibiogram. I see a lot of people talking about their UTI protocols, and I hope that many of you participated in our past programs on evaluation of patients with
UTIs in long-term care. Because that was an incredibly successful program that we'll talk about more and share with everybody who wasn't part of that. UTI is really an area that is so much easier in many ways than others to have successful intervention. So this is great, and thank you for sharing. I encourage everybody to read through the chat and see what your colleagues are doing in long-term care. And so we come to our last polling question, and please open up the poll for our participants to let us know if you feel that the strategies discussed in today's are largely feasible in my facility, not feasible, we have 25 seconds left to answer, not feasible in my facility, or already being used in my facility. And we are interested to know how you feel about what we've presented today so we can be of more help going forward. Okay. Close, and we'll take a look at those results. It was a pleasure to speak to everybody today. After we take a look at this, we'll take questions.
Awesome.
Okay. So we're happy to see that most of you feel that the strategies we've discussed today are feasible, and we really hope that that does come to be true. So, are we at questions and answers? Okay, so I think at this point we are able to take questions, and we'll have the moderators explain how to do that. Awesome. Thank you, Shira. Can you please pass me the ball? Okay. Thank you, everyone. At this time, we'll take some questions. If you would like to ask a question, please press #6 to ask a question over the phone, or you can enter your question in the chat box. We will take as many questions as we can. However, if your question is not addressed during this webinar, we will make sure someone gets back to you appropriately. Again, to unmute your line, please press 6 to ask any questions.
A couple of people asking questions about the slides. They will be available to you electronically after the event. In terms of our facility UTI protocols, we will have an entire 1-hour webinar on April 25th about the approach to patients with UTIs in long-term care.
The slides can be accessed and printed from the following web address, which I will read to you, you can see it now, healthcarefornewyengland.org/event/106. We have a question about the McGear's criteria. The McGear's criteria are actually designed for surveillance of UTI, not as treatment guidelines. So the short answer is no. Better address that in detail in the webinar, which is on detected UTI is on April 25th. So, sounds like there's a lot of interest in that, so please go ahead and acknowledge it.
Sounds like we can hear someone over the line.
From a patient with a catheter, and essentially what I meant by that is after a certain number of days, and the literature show that after about 21 days, a patient with a urinary catheter is a 100% chance of having a positive culture, and that includes if that
catheter is changed and then that bladder will be colonized with bacteria. So regardless of how you obtain that specimen, if a patient has been catheter for 20 or 21 days, that's going to be 100% positivity rate. Therefore, the guidelines say that one should always change the catheter before obtaining the culture if a patient has had a catheter in for at least 14 days, but you're still going to have a high rate of positivity in that case.
Hi, this is Olivia. There is a lot of background noise on the line. If people have pressed pound 6 to unmute themselves to ask a question, please do so now, or if you have not and you did unmute your line, please manually mute your line. Thank you.
And I think we do welcome people to go ahead and ask their questions after they've unmuted, correct?
Yes, that's correct.
Yes.
Go ahead and jump in and ask your question.
Kara, it looks like we have one question from Julie Norman in our chat box, and her question is, does that mean that we don't treat from the positive culture from the catheter?
Right. I mean, basically, the bottom line is that we do not treat cultures. We treat patients. And that positive culture is not what's going to determine whether you treat the resident. It's the decision to treat needs to be based on symptomatology. So, again, we will get into that. We will spend a full hour talking about the approach to a patient with suspected UTI on April 25th.
Hello.
Yes.
I have a question about C. diff. So our algorithm is kind of, obviously if a patient has a positive toxin and they're symptomatic, we would treat, obviously, but then if the toxin's negative, you don't treat. But with a patient who is symptomatic with a positive antigen, then we treat based on clinical symptoms, not strictly just if the toxin's negative, antigen's positive, and they're symptomatic. I mean, we would still treat that, right? I mean, so you're not just treating a lab result, you have to treat the patient, right? It's like straight across, don't treat.
There are many causes of infectious diarrhea. Majority of them are viral. Various gastroenteritis and viral enteritis. But I'm not sure I 100% followed about the test. So when we have a definitively negative C. diff test and clinical symptoms of diarrhea, we encourage not treating the C. diff because that could essentially be anchoring to a false diagnosis, and instead further delving into why the patient has diarrhea.
No, I get that. What I was talking about is, now there's different types of testing. So one of them is, like, when we send our tests out to the lab, it comes back testing the antigen and toxin, right? So both toxins and the antigen. Sometimes the toxin's negative and the antigen's positive. So if that's a symptomatic patient, we're going to treat them based on that because the antigen can be positive because they've had it before, they're colonized, or maybe an active infection is developing, but it's not full-blown yet. But if they're symptomatic with a positive antigen, so it's not definitive, I guess, is my point. And so
right, and those are the patients in which you really have to do that risk-benefit analysis. If you don't have a C. diff toxin, then you are probably dealing with C. diff, the presence of C. diff, or C. diff colonization. And we're going to talk a lot about colonization versus infection in later webinars because many patients who have been in the hospital and who have been in long-term care are colonized with C. diff. And so it's really important then to look at those patients who don't have toxin presence and say, did I recently put this person on a bowel regimen and they need to, that needs to be stopped, or do they have other causes of diarrhea, even antibiotic-associated diarrhea, which may not be C. diff. Every course of antibiotics for C. diff puts that patient at much higher risk of C. diff in the future.
Sure. Thank you.
So a question about asymptomatic bacteriuria even if there's a highly resistant organism in the urine, it's very alarming to see something like an ESDL or a multi-drug resistant organism in the urine that doesn't make the patient any more likely to have a UTI as opposed to asymptomatic bacteriuria. In terms of precautions, precautions for multi-drug resistant bacteria are a very tricky issue. Each institution generally does their own thing, and the guidelines are pretty unclear about what to do about precautions. If you are using urine cultures to clear somebody of precautions because the urine was the original source, then very clearly the answer is no. You do not treat that patient as if they have a UTI just because they grew a multi-drug resistant organism. So asymptomatic bacteriuria is asymptomatic bacteriuria. It is not something that needs to be treated, and the organism that grows should not affect that decision in any way. There's a question about using the SNP test to assess whether or not a patient has diarrhea. I can say that that is a test that has been done here at Tufts for quite some time now, and it kind of goes back to the point of a patient cannot have C. diff diarrhea without having diarrhea. So there must be an unformed stool sample in order to qualify a patient for the diagnosis of diarrhea, of C. diff. So it's really important that there needs to be loose stool to even diagnose the condition. Along with that, most of the assays that are run to diagnose C. diff are only validated on diarrheal stool, not validated on form stool, so you may get some false positives when you run the test on form stool. Any other questions? I see some questions about urine dipsticks. We definitely prefer formal urinalyses, but again, we'll get into very detailed algorithmic patients with suspected UTI on April 25th. Anyone else have any questions they'd like to pose to us verbally or in the chat box? Oh, okay. Question about probiotics for patients on antibiotics. That's obviously a tricky one. There has been quite a bit of research on probiotics in this type of patient population. The research itself is very heterogeneous in terms of quality and in terms of methodology, making it very difficult to put it all together into a conclusion. Cochrane systematic reviews have tried to do so, but even if you look at those, they tend to use a different probiotic in each study, different doses of probiotic, different formulations, and so I think that in general, the evidence is fairly strong that probiotics, certain probiotics, not Staphylococcus, which is what's stated here, but others, Saccharomyces boulardii and Lactobacillus rhamnosus, being probably where the evidence is strongest, are fairly efficacious in preventing antibiotic-associated diarrhea, not really so much C. diff. However, they are also associated with potential adverse events. Generally, they are safe. We have seen in our hospital, and I have seen in long-term acute care, especially when patients have central lines, that the bacteria, or in the case of Saccharomyces, the fungus, have gotten into the bloodstream and caused some pretty serious infections. So there's a risk-benefit there. There's also the risk that if you use probiotics in patients with colitis, so active inflammation of the gut, if you were using it in a patient with active C. diff, for example, that you could have translocation of that bacteria across the bowel wall and get bacteremia that way. And there have been reports of probiotic strains causing endocarditis and liver abscesses. So there, again, like with any medication, with any antibiotic, there's a risk. And actually, we recently took probiotics off the formulary here at Tufts for that reason.
Those are good for you.
Okay, do we have any more questions? Okay. Well, thank you all for the great... Oh, go ahead. Do you have a question?
Okay, Alizi, it's Olivia. It looks like someone has asked for the name of the probiotics that were just mentioned in chat.
Sure. So the probiotics that have been most closely associated with some benefit in antibiotic-associated diarrhea are Saccharomyces boulardii. That's Saccharomyces. Boulardii is Boulardii. That's the brand name for that is, I believe it's Florastor, and then Lactobacillus rhamnosus, CG. So rhamnosus is RHAMNOSUS. The brand name for that one is Culturel. Again, we have stopped using those at Tufts Medical Center due to some serious adverse events that have been reported related to probiotics in other hospitals. Answer the last question, yes. The evidence is stronger for antibiotic-associated diarrhea as opposed to prevention of C. diff.
And it's Olivia again. It looks like I did just get a message that was sent privately to me. Are there any computer programs out there, preferably free, for tracking infections?
This is a money-making industry, and because of all of the, compliance and HIPAA compliance that needs to go into tracking these infections, most of the electronic surveillance programs do require some, funding. The alternative is to have a homegrown product that you build into your daily workflow, whether it be a manual process versus something that's built into your electronic medical record. Those are all options, but unfortunately nothing is free. I have a question.
Hello?
Go ahead. Hello?
We're all on this webinar to learn, to improve, but there's times where I have questions and I don't even know where I can go to ask the question to get a really good, solid answer. Is there any, like I just joined APEX, APIC, just to see if I can't get into blogs and just ask general questions. For the antimicrobial stewardship, where can we really go to get solid answers if we have particular questions about, C. diff and UTIs and so on and so forth?
Well, I think that one of the best approaches, and again, this requires leadership support, but one of the best approaches for small institutions like long-term care facilities is probably to partner with the care facility that has stewardship. And it's kind of setting that up obviously is tricky. The business model itself is tricky, and we haven't quite figured out how to do that ourselves. But Shira and I have both worked with smaller facilities in the past and provided that type of service. And if you can get your leadership to support some kind of consultative relationship with an acute care facility, probably your best resource for questions like that.
Okay. All right. Well, thank you.
And that really is part of what's recommended is having that sort of expertise and that accountability support. Somebody that has that knowledge base, which can't just by having a full-time person there on staff, but being able to at least have a go-to person is really, really integral to being able to have an effective stewardship program.
Right. I just wanted to ask that question because with a resident that had a form stool, they sent it out and it came back positive for C. diff. So what they do, they put that person on an antibiotic. And that's when it's like, well, I just want to be able to sit down or call somebody and say, this is what's going on, and just get some feedback, because I want my feedback to be solid so I can address to the MDs and the APRNs and the charge nurses and so on and so forth. And it's just hard to get that information.
Yeah, no, you're absolutely right. You're absolutely right. And the Infectious Disease Society of America is really pushing that very important agenda that, if we're going to be asking long-term care facilities and, really this initiative is going out to all types of healthcare settings, dialysis units, freestanding surgical centers. If we're going to be requiring all of these types of facilities to have stewardship, we have to be able to provide them with the expertise. And so that is something that needs to be, I think addressed on the state level, on the national level, is how to facilitate relationships between these small facilities and academic medical centers, ideally, that have infectious disease physicians and pharmacists to be that go-to for you guys.
Well, moving forward, the next webinar, I'm going to definitely encourage, because the morning meeting, I mentioned it, for people to come in, but the next webinar, I'm going to encourage the unit managers, charge nurses, ADON, and the APRNs to sit in on the webinar, because this is so important, and you gave us so much good information that I hope you repeat this first webinar at the end, just so they can get the beginning of it too. But I'm going to push and let them know that this is very important. Everybody needs to sit at this webinar. Everyone, I think there's 8 of them they're going to give us, and I think they all need to listen to all 8, because we all need to get this.
Well, thank you for that feedback. And actually, the next one will be especially useful for the really end users, because we're going to talk about strategies, how to get the ball rolling. That will be really great for unit managers to kind of.
Well, thank you for your time.
Thank you. Thank you.
Great. Thank you all for a great discussion. I have a few last announcements before we end today's call. A reminder that we are now on social media. Visit us on Facebook, LinkedIn, and YouTube page. We are currently giving away, you can win a copy of the Staff Stability Toolkit at a value of $75. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow with the link to the evaluation, as well as the link to the event page on our webpage. The PowerPoint presentation was in your Day of Details email and will be posted on the website. Within the next few business days, a recording and transcript of this webinar will also be added. Thanks again for attending, and have a great day.
The leader has disconnected. The conference will be terminated in 5 minutes.